So happy leap year. I was thinking to this day, like, you know, this is the one day a year that you can do something that you really regret, and there will only be a quarter of the anniversaries of it. And so if you want to look at it that way, it's a good day for that. It is also a very cool day, I think, for us in that it's Rare Disease Day, and Dr. Nelson, Connie Nelson, came to us and had this wonderful idea for, did I say Nelson? Yes. Taylor. So sorry, I do that a lot. I'm sorry. Connie Taylor, wonderful Connie, came to us and with this great idea in presenting this topic today, and kind of traumatic sesh for our patients, especially those that go through a you know, kind of constant medical visits and tests, and you know, just a lot of things that we think are incredibly normal because we do them every day, but are a huge thing for our patients and our families. So I'm really delighted to have Connie Taylor, one of our peds neurologists over at Avera Medical Group. She's assistant professor at the Pediatrics and the division chief of neurology at the Sanford School of Medicine. She's a native of Maryland, which I actually didn't know that. It's taken me a little, had to remember all of this, I guess. I might have known it. But completed her graduate training in neurology at Harvard College, received her medical degree from Morehouse College, Medicine, and then went on to complete a pediatric residency and child neurology fellowship at the University of Chicago. She kind of likes that cold Northeast weather, yeah, ish, Midwest, I guess. Fortunate to have recruited here to Sanford in 2015. Then she went back to training to complete a neurophysiology fellowship at the University of Minnesota, and then brought that back to USD and Sioux Falls in 2018 over at Avera. So she's a strong advocate for patients with complex neurologic disorders. Today has invited a special panel of guests to help us understand how to prevent medical traumatic stress when caring for our patients, our pediatric patients with complex medical conditions. So welcome, Dr. Taylor. I'm gonna let her introduce the rest of her panel.
Thank you. Is there a microphone I should be speaking into, or just talk?
You can just talk as long as everybody feels like they can hear you, whether you can put a microphone.
Okay, as long as online can hear me too. Perfect. All right. Well, I am speaking today with Jordan Haberman and Wendy Jensen. Jordan is a 13-year-old local student. It's a privilege to have her hear her story today. She is going to share her story about living with a rare disease and receiving care in our local hospital systems. Wendy is a certified child life specialist for 20 years, and she works in the Castle, Sanford Children's Hospital. She cares for many children locally for with a variety of medical illnesses who undergo procedures here at the Castle. Before I kind of talk about our talk, which is about preventing pediatric medical stress, traumatic stress, I want to highlight that today is Rare Disease Day. The pediatric department was nice enough to get some cupcakes, some rare disease cupcakes from Oh My Cupcakes today to just highlight the day. So I just wanted to kind of define rare diseases for everyone so we know what we're talking about. So a rare disease is any disease or disorder that affects, in the US, less than 200,000 people. So individually, rare diseases are rare, but collectively, 1 in 10 people has a rare disease. So we all know someone who has a rare disease. We've all treated someone who has a rare disease in the medical field. Many of us probably have rare diseases as well. Some examples you might have heard of: cystic fibrosis, sickle cell disease. Most childhood cancers would classify as rare diseases. Many of the genetic and neurometabolic disorders that I treat are rare diseases as well. So Rare Disease Day is a patient-led advocacy event that's really just to get awareness of the day and to get people talking about rare diseases, because what we really need is more funding for treatments and to help with diagnosis of these disorders. We're finding that more and more rare diseases, though, are genetically based and that they start in childhood. So 70% start in childhood. So it's really important as pediatric providers that we are aware of rare diseases and we are aware of the effect they have on our patients and how important it is to be a part of this diagnostic journey. So a lot of people find it takes years to diagnose their disease, and we're hoping to shorten that down, especially for these genetic disorders. So I get permission to share this, but I came to know, I don't know, I never took care of Jordan personally, but I came to know her family through care for one of her siblings who was diagnosed with a rare disorder. And it was really because of the availability of genetic testing that diagnostic journey went from what would have been months to years of really painful procedures to weeks to months of kind of genetic testing that kind of shortened that journey by a lot. So that's why rare disease day is important, because without the funding for those types of genetic testing or the research for the metabolic treatments, 95% of rare diseases don't have a treatment. So it's important that we just talk about it more and we get more research done for these type of disorders. All right. Today we'll be focusing on pediatric medical traumatic stress and understanding the importance of it in our patient population and importance of prevention of it. Obviously, we all know that pediatric population is a unique population. Our kids have unique needs and their families as well in the medical setting. In the process, especially, and we decided to do this on rare disease days is because so many kids, as they're going through this sometimes year-long diagnostic journey to find a diagnosis, go through a lot of very painful and invasive tests and treatments. And we want to do what we can to limit the stress that we're causing to patients and their families. So we're going to do a talk in 3 parts today. I'm going to talk a little bit about just the introduction to what pediatric medical traumatic stress is. And I'll talk about how, as healthcare providers, we can lessen our role in causing stress to our patients. Wendy Jensen is going to talk about child life and how her approaches to medical trauma, and then Jordan will share her perspective as well. I do want to also just highlight how privileged we are to have Jordan here today. I think the most important part of Rare Disease Day is patient stories. I think whenever I meet someone, a new patient with a rare disease, even if they come to me with a diagnosis, I try to ask how the diagnosis was made, what their initial symptoms were, because I think the more we talk to people and hear stories, the quicker we're going to make diagnoses, and the quicker the less hurdles patients have to go through to get to diagnoses and get to treatments as well. All right, a quick disclaimer because we only have an hour here today. So we're going to talk about the prevention of pediatric medical traumatic stress. While it's very important, and we're not going to have time today to talk too much about treatment. So that is, it's very important, but we'll kind of touch on it a little bit. And then I also want to mention that we're not going to talk about traumatic stress in caregivers as much today, or the secondary traumatic stress in healthcare providers, even though it does occur. And it's something I encourage everyone to learn more about. And I will say, just if you want to read more about it, I will have all pamphlets that I'll put at the table. But the National Child Traumatic Stress Network has a lot of really good information about medical traumatic stress. And you can read about secondary traumatic stress and caregiver stress on this website too. All right. So I said I'm going to focus on just the introduction to what pediatric medical traumatic stress is and how physicians and healthcare providers can help lessen and prevent that stress. So for people in the room, raise your hand if you in the last year have gotten a shot. Right. Keep your hand up if that shot hurt. Keep your hand up if you thought about that pain 10 minutes later. Okay, all hands are down for people who can't see. So most of us, shots are not pleasant for anybody, right? But for most people, within 10 minutes of the procedure, probably within 5 minutes of the procedure, we've already forgotten about the pain. It's not really affecting our day-to-day life. I'll give an example of my 4-year-old daughter. I took her for 4-year-old shots this year. There are already a lot of 4-year-old shots in addition to having influenza and COVID on top of it. And she was terrified going into the shots. Afterwards, I would say an hour later, dropping for daycare, she's still talking about the shot. She's telling all her friends at daycare how traumatic it was. But I think it's just I want to highlight for traumatic stress, it's not the experience, it's how someone goes through the experiences. It's subjective, right? What's traumatic for a 4-year-old may not be traumatic for a 40-year-old. And there might be 4-year-olds who having shots are not traumatic, but everyone has a different experience. I just want to highlight that it's not, a lot of us may dismiss what people go through thinking that it doesn't seem like it would bother people, but everyone has their own personal experience. So traumatic stress, really a reaction to pain, injury, serious illness, medical procedures or invasive or frightening experiences. Children who go through pediatric medical traumatic stress, that's a mouthful. So often after a life-threatening illness, a procedure, being in an ER hospital, sometimes something as simple as just being left alone for a few minutes can cause traumatic stress in a child. Sometimes being exposed to medical equipment. So we go in a room and we're used to everything beeping and the drips, but kids, just the experience of being in that room can be really traumatic for them. Some kids are able to cope really well, but some require some extra support. There are a lot of different risk factors for kids to develop pediatric medical traumatic stress. So if kids who have a previous traumatic experience are more likely to experience medical traumatic stress. They don't have peer support if their parents are absent during the time of the trauma. If they have pre-existing emotional or behavioral disorders, or they experience a high level of pain. Those are all things that can predispose kids to having more traumatic stress. So 80% of children who experience stress after a life-threatening illness, injury, or painful medical procedure will have some degree of traumatic stress, but it's only persistent in about 15-25% of kids. And this, again, it's individual dependent, but it's also dependent on the experience that they have in the hospital. I just wanted to kind of mention, I'm throwing out a lot of different words here. And so these acronyms here, on the right side, ASD is acute stress disorder, PTSD is post-traumatic stress disorder. So these are both kind of acute stress disorders that are in the DSM-5. These are medical disorders that are for acute stress disorder are short term, so less than 1 month reaction to a stressful traumatic event, not necessarily a medical event, but any kind of traumatic event. So it could be war, natural disaster, assault, anything that is traumatic to the individual person. And a post-traumatic stress disorder is a prolonged reaction. The other two examples on here are post-traumatic stress symptoms and pediatric medical traumatic stress. So there's a lot of overlap in all of these terms. I just want to point out that some of these a little bit might be used interchangeably, but they're all separate. Post-traumatic stress symptoms, PTSS, is not a medical disorder, but it's just the symptoms of having, essentially it's the symptoms of PTSD without having a diagnosis of PTSD. And then pediatric medical traumatic stress is basically a subset of those symptoms, but if the traumatic event is a medical event. So there's probably the most overlap between those two. This is kind of a, okay. So this is a kind of a schematic of what a pediatric medical traumatic stress model. So we have the trauma. So this is and this x-axis, sorry, is time. So over time, the first thing you experience would be the trauma, and that could be, again, subjective. So say someone is admitted to the PICU and they're intubated. That would be a possible procedure that would be traumatic to a patient. The acute medical care might be the rest of the hospitalization, and then the discharge ongoing care is as that patient's either discharged or if they have a prolonged hospital stay, the kind of the rest of the hospital stay. But over the course of this hospitalization or this illness, you have, and I want to emphasize that it kind of breaks down to resilient. I'm not saying these are resilient people, it's just a resilient response to the trauma, because everyone can be more or less resilient in different circumstances. But as time progresses, if we're not necessarily screening for risk and working hard to prevent medical trauma, then what can happen is the traumatic stress is higher, and it can escalate or become chronic if we're not being very active as healthcare providers to prevent or lessen that stress. So pediatric medical traumatic stress can look a lot of different ways. The most common would be kind of re-experiencing, so intrusive thoughts about the illness or feeling. An example would be, I could tell, when my daughter got her shot, right? If I mentioned the shot later that day, I could see her physically stiffen up, and she's re-experiencing that shot, the pain that she got from that shot, because of the medical traumatic stress she has from that experience. Avoidance, so less interest in a certain activity or feeling numb. I use my daughter a lot, for example. So we had, when she was at the Mall of America and she slipped on one of the escalators and she got kind of banged up her knee, had to get, she didn't have to get stitches, but she went to go see the urgent care. And to this day, she still won't go in escalators, right? So she because of this experience she had, this traumatic experience she has, she avoids escalators because it reminds her of that trauma that she experienced there. Then hyperarousal is just irritability, difficulty concentrating, or kind of an exaggerated startle response people might experience after trauma. So this would be probably example I can give is I see a lot of patients with seizures. So, and this is an example in parents, but after a kid has a seizure, often their parents are very hypervigilant, right? They're sitting by their bedside. If a kid has a febrile seizure, every fever, the parents are waking them up, checking fevers around the clock every 2 hours. So they're hypervigilant. They're very kind of hyper aware of anything that could change because of this previous event that kind of caused trauma. This may lead to others. I put kind of an grayed out a little bit, but other less common symptoms of PMTS would be having new fears, somatic symptoms like GI complaints or headaches, or feeling that numb disassociation. Medical traumatic stress can impair daily functioning. It can decrease compliance with kind of a medication regimen, especially if someone if one of their symptoms is avoidance of medical care or certain institutions, and may delay recovery because of those things as well. So this is just a model of how people in the healthcare system can approach medical traumatic stress. So I think of the bottom layer is kind of universal precautions, how we all wash our hands, go in the room, but basically everyone who comes in, we're thinking about ways that we can prevent medical traumatic stress. So this would apply to all physicians, nurses, child life workers, social workers, just to be aware, and we'll talk about ways to be aware, but wait, for everyone coming in, there should be a baseline level of just acknowledgement that what we're doing causes stress in a lot of people. And then once we identify different risk factors, I talked a little bit about those before, certain people are increased risk of having traumatic stress. So we might have more targeted approaches to those individuals, such as calling a child life specialist to help. And then again, we're not going to talk too much about treatment, but if it's escalating or very severe, we might have to consult behavioral health or other kind of higher level help to help with traumatic stress. All right, so the idea for healthcare professionals is after we kind of work with the ABCs, our next step is DEF. And DEF is our ways to think about dealing with traumatic stress and preventing traumatic stress. And this kind of, it's highlighted, I'll put these brochures out, but it's kind of highlighted in this brochure as well. So looking at distress, so it's assessing and managing pain, asking about fears and worries, considering grief and loss in patients. E is emotional support, asking who and what does the patient need right now, thinking about barriers to mobilizing support systems for that patient, and F is family. So assessing parents and siblings' distress, gauging stressors for the family, and addressing other needs. I'll go through briefly each one of these a little quicker, but so for distress, this is probably, I think, the one that we can do the most about, but limiting distress. So the first thing I'd recommend doing is just providing as much information as you can to the patient themselves, explaining what you're doing, why you're doing it. And I think obviously at an age appropriate level, but I wouldn't dismiss kids who are younger and think they don't understand. I think there's always a way to explain what's happening in a way that a patient can understand have some understanding of it. Always be assessing pain and making sure we're treating pain adequately. Listening to the child and asking what they understand. Because I think we can always assume that people understand, even for parents, obviously we assume that parents understand and sometimes they don't. So asking the patient what they understand and having them repeat it back to you. I think it's really common for kids to think that they're having a painful procedure because they're being punished for something. And if they go through the whole hospitalization, having that understanding, then that's going to create more stress than if they understood that we're trying to make them better. Another example is often for lumbar punctures, people think that they're going to get paralyzed afterwards. That's a risk. But I think explaining like how we're taking steps to go beneath the spinal cord, I think people are very soothed if you explain, understand their fears and address them rather than kind of blowing over them. And even if it's takes a few extra minutes. Clarify any misconceptions like the ones above, provide reassurance and hope when it's realistic. So for me personally, I try to limit my exam, especially in like my outpatient setting in the clinic, to when it's really necessary. I often have kids who they've seen multiple specialists, they've gotten poked and prodded at every visit, and they're terrified of doctors, right? So a lot of patients when they come in, if I notice they're clinging to their parent or they're very distressed by the whole encounter, if I know that I've seen them before and their exam has been stable, and I know that the exam today is not going to change, sometimes I'll give them the option. Do you want to have a neurological exam today? Do you want me to listen to your heart and lungs? And most patients say no, which is fine, but it gives them a lot of confidence and empowerment to be able to say no, right? And if it's not going to change anything, then it doesn't hurt me. I wouldn't recommend giving that option if you know that you need to do an exam. Don't give someone the option, because then it's not fair to say, no, you don't want one, then you're going to do it anyway. That's kind of not helpful in building a trustful relationship, but it's helpful to give people choices. Emotional support. So encourage patient, current parent presence. Empower patients to decide what position for things or where their parents are in the room, especially in the outpatient setting. A lot of times doing an exam on the parent's lap or doing shots on the parent's lap is a lot easier for patients. It might take a little bit longer for providers, it might take longer to give shots, but it's a lot easier for patients, and a lot studies have shown that pain is less if they're in their parent's lap. And then for kids, especially who are in prolonged like hospitalizations, encouraging them to have some involvement in kind of their normal activities. So talking to friends, video calling, writing letters, things like that can be really helpful. And then family. I did say that we're not going to talk too much about family traumatic stress, but I think it's important to say that we can't, limiting some stress in the family is limiting stress in the patient, right? Parents need to eat. It's really common. You're a parent in a hospital setting, they'll go a long time without eating because they're so fixated on their kids, or they don't take a break to just walk around the hospital. So checking in on parents after you check on the kid is really important as well. Emotional needs of the family, so that is getting social worker or chaplain involved, making sure that if there's other resources they need, that they have access to those. This one takes a little longer, but like listening to parents, the angry parents or withdrawn parents, talking to them a little bit longer. I often find that parents who are initially very angry are often just worried and scared. And it just takes a little bit of extra time to talk to people and understand why someone's angry and what they're angry about. And then think about resources that might be helpful. So that might be the Ronald McDonald House or meal vouchers, or just asking about food security or transportation to and from the hospital. That can go a long way in supporting a family, and when a family is supported, the patient's supported as well. Lastly, I just want to talk a little bit about kind of patient and family-centered care. So family-centered care is focusing on respect for the patient and the family. It's shared decision-making, with the healthcare team, and encouraging the family and the patient to have a presence and to participate in the medical decision-making. Trauma-informed care, which is kind of the DEF that we've talked about before, but it's realizing that trauma is widespread and that we are causing a lot of the trauma that that's happening. Realizing how it affects patients, their families, staff, and organization, and responding to and applying our knowledge and things that we know might lessen trauma in families. So that the combination of patient and family-centered care and trauma-informed care is what we're going for here. So sharing information, this is kind of more again with the DEF things I've mentioned before, but sharing information with the patients, encouraging families' presence, considering choices, emphasizing families' needs and their strengths, and in a culturally competent way. That's all from me. I'm gonna invite Wendy up here, our certified child life specialist, and she's gonna talk a little bit about the approach that child life specialists have.
Hi guys, my name is Wendy. I've been with Sanford Children's for nearly 20 years, and I'm honored to be here today. And I feel like I'm totally just echoing what Dr. Taylor said with what Child Life gets to do every day here at the castle. And I know Avera has child life specialists as well. It's super important that we give a voice to kids and families, and our role as child life specialists is just that, to advocate for their needs. And so we want to just buzz through some things, and actually what Dr. Taylor said are some of the risk factors that I think are important to are worth mentioning. But it is important that what child life specialists are doing and what we're doing in the castle is not just what we think is best. There is a lot of research behind it. And Lots of very intelligent people have done lots of research to show that in order to help kids best cope, if we give them preparation, they are going to have a better outcome. That fear and anxiety is going to be lessened, and they are for a lifetime going to be more successful in their medical coping, and their compliance as adults is going to be more successful. So some risk factors, quite honestly, the hospital is a scary place. Clinic settings are scary places. We live and breathe here every day while we're working, but a lot of these families and kids do not. Some of the things that she had mentioned, new environment, unfamiliar equipment, new people that they've never met, painful procedures, change in routine, fewer choices. I mean, the list could go on and on that we could do. And then the flip side of that, we have a lot of kids, I work in the subspecialty clinic. So a lot of those kids have maybe, we're saying unfamiliar equipment and new environment. Some of them are all too familiar with it. And they have come over and over and over, and they are way too familiar with it, and they are manipulating the medical equipment, which is awesome in child life's perspective, but they have had to grow up in a hospital setting. And so that is also a risk factor, because we have plucked them out of what's good and normal in development, and we've said, here, grow up in a hospital setting. And that's not good and positive either. So those are risk factors for stress. So what can we do as medical professionals in this setting? I think it's really important to lift up that whether people are learning, watching from home, or not every facility, whether it's outlying clinics, there isn't child life specialists in every location. And so we want to always give tools and tips and tricks that people can do and have in their toolbox to be able to utilize in outlying areas, because we want kids all over our footprint and all over in hospital settings to be able to cope. And so we know that a child life specialist can't be called in all areas. And so what can we do? So I'm going to just actually kind of skim over these, because Connie had mentioned so many of them. But these are things that we want to keep in the back of our mind as you're going into exam rooms, or you're going in to do maybe your initial assessment, your first meet and greet with them. That a lot of kids, obviously their developmental age doesn't always match their chronological age. What's their temperament? What's the anxiety of parents in the room or their caretakers? How are they coping with new environments? Are they adaptable kids? Have they had lots of hospital experiences? So all these things to quickly try to be thinking about as you go into rooms. Maybe they're an admission kiddo, or maybe they're a clinic kid, but to try to be thinking about as we walk into rooms, because those are all the foundations of what we're walking into and how we can best help kids. We need to be able to have those in the back of our mind as we move forward. And I mean, when you think about this, is so much to be thinking about in a short period of time. If you're trying to do this in a clinic setting, and the turnover rate that you're trying to do is just huge, you're trying to get patients in and out the door. And we talked so much about giving them the time that they need, and the genuineness and being present. It's so hard to do because you have just full clinics and you're trying to be present with all of these kids. And it's just a lot to ask of healthcare providers, as the pressures from all areas. And it's the reality of what healthcare is, I think, and the pressure that you all feel. And we are asking, from a child life perspective, a lot of you guys as providers and clinicians to take that extra time. I think when you look through this, like, I mean, lots of it speaks to me, but the bottom one, like, we would want this for our own kids if our kids were in these settings. So, and we are the experts in working with kids and families, and people come to us expecting that, whether they're coming to Avera or they're coming here to the castle, they want the best for their kids. So what can we do? We're gonna skip over this one because we just, for the sake of time, we have child life. We've come up with something, it's a universal language that lots of child life specialists speak. Something that we try to empower other people, we call it the 3 Ps. Something that is kind of a buzzword that you can use and have in your back pocket to be able to be mindful of. And we thought that that's something kind of tangible. And so you could see those, and we'll quick run through what they all mean, and I'll give some examples of each of them. So the most important one, and it kind of happens pretty quickly, is preparing the child, the patient, and staff as a whole, like what our plan is as a whole. And this happens simultaneously, and it can happen organically as you speak. A lot of us probably do that. So you're using your senses as you speak to kids. You're talking about cold soap that you're going to use. You're talking about a tight band that you're going to use with the tourniquet. You are giving as many choices as possible. So perhaps it's an IV start, and you are asking them what arm you would like them to utilize first to look at. You're going to use the senses to talk about where they would like that tourniquet to be placed in tight band, cold soap, tell us what you feel. So utilizing all of the feelings that they're going to be having, you're preparing the child so they can understand the chronological steps of what's going to happen. Often we are challenged when we do education and outline clinics, like people will ask and say, there's no way we can get this done in a timely manner. We don't have enough time to do all this and get done what needs to get done and be able to move on to the next patient. But there is, because so much of it can be done as you're doing it. It can be done simultaneously. So if you have an opportunity to give a few choices, all of a sudden you've gained a little bit more trust, and you've established a little bit more rapport with them. And that's happening just very naturally as you keep going. You want to give a plan for, and I'm using an example of an IV start. You want to give a plan if they want you to count before they poke. And that's giving some mastery, some power and control over their situation. As you're doing that, you're giving a plan for the parents, because we want to set expectations for parents too, whether it's a comfort position that Dr. Taylor had talked about, and we'll talk a little bit more in depth about that. But we want parents to understand the reality of, example, IV start. Sometimes they don't go as planned, and sometimes, quite often, it takes more than one attempt to get an IV in a dehydrated child. And so we want to not set the expectation that we're going to get it on that first poke. And so when a child asks, is it going to take one poke? We're going to be honest with them. You know, our friends are going to do their very best to try to get it on the first poke, but we don't know. We're going to see if that little blue line cooperates. You have a job. The nurse has a job. Mom and dad have a job. Mom and dad, your job, or whomever is going to be doing the holding, is to try to hold that child as still as you can, or whatever position you're in. But you're going to give that parent some responsibility, and then they feel like they're a part of the equation. We so often, parents, we don't want them to feel like they are on the outskirts of what's going on. They know their child best, and we want them to feel empowered to be able to speak up and advocate for their child. And so being able to be there and be present. And so if we've prepared the child, if we have just a few extra minutes, or you're doing it as you're getting ready to do a procedure, you've prepared the parent and allowed for a few questions. Kind of the caveat to that is we really try to keep the conversation or the education positive. We've all been in those situations where parents want to go down a real negative road. Oh my gosh, we've had a terrible IV start, and one time this, and then they go off on a tangent and they want to start talking about an IV start that took 7 pokes. And we want to validate that, and that's a very real thing. But in that very moment, as you're getting ready to start that IV, or you're getting ready to head to CT scan, or whatever the procedure is, that's not the time to talk through and unpack that negative situation. And so to try to redirect that and bring that back to something positive. And then we want to have a plan for the staff and what we're going to do all together as a unit and who's doing what. And so that way then we all kind of can work together. We have a common plan, and that can all happen in just a really short period of time. The thing I skipped over was one voice, and often in a procedure, and I'm using IV start for simplicity reasons, but it happens all the time where naturally we as caregivers, we want to do the very best. And so we are caring humans. And so we are all cheerleading per se for that patient. But what's happening is the room becomes totally overstimulating, and someone is saying, great job. And someone else is saying, you're holding so still and I'm so proud of you. And then mom and dad are also comforting child perhaps, and maybe child is crying, and then there's an iPad going, and all of a sudden there's 6 people talking and child crying and an iPad going, and it's so overstimulating in that room that if you take a step back and you just observe what's going on, the like intensity level in that room is just crazy. And so the acronym we use is one voice, to just try to be mindful and see if you can bring that level down to almost be the emotional barometer to let the room like remain calm. So if mom is doing a wonderful job of comforting child, then let mom be the one to comfort child, and let the emotion in the room like move towards mom's voice. And then we as healthcare providers to utilize some nonverbals and to be able to speak to each other with our eyes of what you might need from the table, or who you might need to have another hand come into the procedure to help stabilize an arm, and lessen that medical jargon that's happening all around. But naturally, as things are going well, we continue to cheerlead because we care and we want that patient to feel like we're super proud of them. But if the next time you're in a room and something's happening, maybe it's in peds outpatients and they're sedating a patient, or someone's port is being accessed, listen and watch for the intensity in the room. And if you're hearing like one voice of support, or if you're hearing a multitude of people, and how intense that starts to get. And it just naturally happens and people mean well. So it's worth bringing up as you prepare and come up with a plan for what's happening. So I'm gonna skip through this because I know Jordan has important things to say to us too. We just want to give everybody a job, so parents feel like they are a part of the equation. And then we do know that there are several opportunities for them to have a position of comfort, that they can also be holding the child. And we hate to use the word like restraining, but they're helping to stabilize the child, but they're also comforting them. It's way better than us as strangers doing that, although Child Life, we certainly will help with comfort positions. But we do know that there's some parents that their anxiety level is just too much and it makes the room too intense, and that it is sometimes better for them to step out, and you can decide that as a team to figure out if that's gonna be better or worse. So we have a multitude of things that we are currently advocating for and we use. These are things that we're utilizing in the castle. I'm sure that many of you have seen them. The simplest and least invasive and cheapest right now is Buzzy, which is essentially object that sits on top of the skin that goes between where the pain is and pain receptors, interrupting that pain receptor, causing vibration, allowing for the pain receptor to get interrupted for a short period of time in order for the practitioner to do what needs to get done. So we're utilizing it for IM injections or vaccines. We utilize it quite a bit, actually, even for finger pokes in oncology. They'll hold it in their palms. I haven't done any research to see if that's actually like the correct way, but our oncology kids are telling us it's amazing, so we're going with it. We've had really good luck with it. We, because of infection control and the amount of times that we're using Buzzy, we're not using the frozen wings. There are some frozen wings that can be attached to the backside. We're not using that right now because we just can't keep up with that demand for it. Sugar water, sweeties with our babes, EMLA cream, we'll utilize over the top of our portacaths or IV starts, placed on the back for lumbar punctures. Our pain ease is utilized not as much. I don't know if any of you have ever tried it. It is a stinging sensation, or feel, the way we describe it to kids is it feels like when you put your hand on something super cold and your brain says pull it away, but you continue to leave it there. So it's been intense. J-tip we've had wonderful luck with. We use quite a bit and advocate for, and then just warm packs or even just a bag of water to help warm that site. So all of these things obviously have amazing effects, but it also shows big picture to that family and to the child or teen that we're trying our very best to do something to help, because we have to get things done. We have to do hard stuff. We have to get IVs or lumbar punctures, or we have to do biopsies. We have to do things, but what can we do to help manage pain? So these are some things that we are currently doing. So comfort positions. Let me back up just a little bit. So when we talk about things that we do to decrease pain, those are the pharmacological things. We want to talk about things that we do in Child Life, and we don't have time to go off on all the different avenues that Child Life utilizes, but some very simplistic things are utilizing distraction, and so those are available for people. Lots of people have devices in their pockets. Obviously, you can families can put videos on to try to keep their kids busy, but something that does work amazingly well is deep breathing, and something so very simple. Breaths in your nose like you're smelling flowers, blow it out like you're blowing out birthday candles. And you don't have to have anything with you. You know, people will say like, well, I didn't have anything for distraction. You have that because you just say that out loud, and you can really get a child. And even if they're 3 years old, they know how to blow out a birthday candle. So those are some easy tricks and tips. We want kids to feel like we are doing all that we can to give them opportunities to feel like they have some say in what's going on. We're trying so hard to make it not be so hard for them. So these are some simple things that we do on a pretty regular basis. Comfort position that Dr. Taylor had mentioned. I'll just quick skim through this. I'm gonna go actually and just show you the pictures. They got a little bit out of order. So these are some of the distraction things that we have around the castle or carry with us. A lot of you have seen them on a regular basis, but these are some of the comfort positions that we use daily. That chest to chest position often for our kids with port accesses. We hardly ever lay kids down for a port access. They sit up on parents' lap, or they sit up right on our exam table. Helps with the breast tissue being able to, typically those ports are up higher here, helps with the breast tissue being able to gravity. Chest to chest is one we utilize a lot. Those are ones, and you know, we're really working hard advocating in our emergency department to utilize more of these comfort positions too, because that's a frontline area that a lot of our kids are coming into. Dr. Taylor and I were visiting. She asked, how many kids through the castle do you think Child Life touches? And so I quick messaged our manager, and last year our stats are Child Life saw over 8,000 kids last year. And that, when you think about it, that is a whole lot of kids and a whole lot of opportunities for stressful situations that kids are exposed to. And we want to give opportunities for that foundation for them not to have fear of their medical world, and we want them to feel like they have choices. And so all the things that I quick breezed through are different opportunities that we can quickly give to kids and families in short period of time. And it seems like it could take so much extra effort. It just really doesn't, and it kind of becomes second nature. And we're pretty blessed in the Children's Hospital to have this be something that we do on a regular basis. But it's those outlying places that we really need to continue to promote, and we want this to be something that just becomes an expectations that parents can have for our outlying areas too. So when we talk about all of these things, Dr. Taylor and I can go on, and we can lift up all the amazing things that we know that research says this can provide for kids. But the important thing is that firsthand, my buddy Jordan and her brother for years have been coming to the castle, and we have seen the impact that being able to give some power and choices and being able to have some control over the situation has done for their ability to cope. And by taking a little bit extra time, they have come through some really hard things. And so Jordan came to us today and missed a little bit of school. And so we wanted to have her share a little bit about her story, if she would, because she is a shining example of what it is like to have kids feel empowered. So do you mind coming up, Jordan? With you.
My name is Jordan. I'm 13 years old. I like to read. I like music. I'm in choir. I'm in show choir. I play violin. I'm in theater. Yeah. So you might be wondering why I'm here today. I've had a lot of experiences in doctor's offices and clinics, and most have been miserable, terrible, and dramatic, and have left me angry, frustrated, and distressed. I can't even watch my brother get his IV start, which he gets every 2 weeks. There was a long period of time where I had to sit outside of the doctor's room because it would just make me so horribly anxious to just hear it, what they were talking about. I had to switch dentists.
Yep, Jordan and her brother have been through a lot, and I think that as she reflects about all of this, it stirs up a whole bunch of emotions, and it's been from the time that they were little that they've been part of the hospital world, and so she's had to work really hard to overcome a lot of things. So tell us, what do you feel was really important that was helpful to you?
So I think it's really important to give the patient options, even if it's just as little as like, what color Band-Aid do you want? Or like, should we do this in the right arm or the left arm? Or like, I don't know, you want something afterwards? And then as Wendy said, the best for me personally is to just walk the patient through, because it's terrifying to just be your parents talked with the doctor, you didn't understand any of it, they're throwing around language you don't understand, and then you get pulled out of school one day, and then the doctor does random stuff to you that's like could be really invasive. The best I think is to walk the patient through and say like, okay, well, first we're gonna do this, and like even as you're doing it, you can do that. It can be really helpful. That's the best for me. And this goes along with giving options, letting them be in control of their body, is really important, because otherwise they feel as if like they're being forced to do stuff. Choices are really important. If you like, one other thing that really helped me was like, so I'm gonna use like dentist as an example. So this is my brother example. So he went to the dentist and he was supposed to get like a cavity filled and like 3 teeth pulled, but they were also like, it's as many teeth as you can, as you feel ready to today. If you want to, you can come back later and we can take the rest out another time. And yeah, and if that happened to me, it would be really great. Not breaking trust is really important. Saying like, hey, look over there, and then just like giving them a shot is really harmful. It just breaks trust. They're never gonna trust doctors again. One tactic that really helps me with my anxiety is diffusion. You like can ask them like, what are you worried about? Do you think this worry is helpful to you at all? And stuff, you know.
Those are great examples. And I mean, it really does shed amazing light on all of the things that we lift up all the time, because Jordan can speak to that for years of having to get to this point. Why do you think that you wanted to tell your story today?
I think it's important to tell my story because there is a cost to just treating patients, especially like children, as like objects and like diagnostics, like, oh, they're too young to decide for what they want for themselves, and just like treating them with, I don't know, as quickly as possible and moving through. There's a heavy cost to that, and it's not worth it. Kids aren't objects you can hold down and jab with needles and poke and prod. Like, even if they're as young as like 2 or 3, or 4 or 5, they're gonna remember it. Even if like me, they completely block it out of their minds, like the anxiety of that moment is still gonna be there. And the trauma can heal, you can learn to deal with it, but it never goes away. Like the lasting impact is horrid, it stays for life. Even now, I still struggle with this. And if you say like it's not so bad, or like lie to them, then they're never going to trust you again. There was a time in my life where I thought doctors just wanted to hurt me. It sows the seeds for distrust for the rest of their life. And it's an undermining of people's feelings. It's dishonest, it's degrading, and it's demeaning. One example I have is when I got like nose tube or whatever. I don't even remember what it was for because they didn't explain it to me. But like, it was incredibly overwhelming seeing like 4 nurses come into this room while I was laying vulnerable on the hospital bed. And then they just kind of held me down and put the thing down my throat.
Yeah, that's hard stuff, isn't it? It just takes so much energy to dig back from that, right? A lot of energy. So what do you hope that people take away from this today?
Kids aren't objects that they will remember. Like, just shut up and go along with it isn't the best strategy. It's not a good one at all. Like I said, I felt the doctors just wanted to hurt me for a long time. And like the going along with the like walking them through part of it, there was one time where I went to a doctor, obviously, and then my parents were there, and like they talked to my parents as if like I wasn't there. Like she talked right through me, describing like 6 procedures that I should have done, and they all sounded horrifying because there was nothing, like I just had no reference for what they would look like, and it sounded like she was saying that I had to have them, and like in the very near future. They were terrifying. It was probably the scariest moment of my life. What I hope you take away is that you should really just take the time to help comfort kids because they never forget.
Jordan, thank you. Appreciate it. We're grateful for the time today. I know you guys are super busy. We do think that it is super important to have that extra moment because we do make a profound impact on kids' lives every day. Thank you.
With Jordan's permission, of course. Thank you. And I wanted to highlight, this is an event I'm associated with, but there is a rare disease today Rare Disease Day event at the Overlook Cafe tonight, if anyone's interested in going. I think Sanford Research is putting it on. Then some references, and we're happy to take questions if Dr. Bach.
I really appreciated you saying I like what that helps to remind us as physicians that every patient that we see is like ourselves and our kids. I was wondering if I've been through some trauma with my own kids, and to me, we've all had our own traumas, but watching your child go through traumatic events is also very, very hard. And sometimes with a new diagnosis, as a child, now my growing kids tell me that watching me suffer made their suffering worse. Is there tips that you can give to parents or to doctors to kind of help mitigate that? Did it scare you to see your parents cry? Are there things that you can think of that we can help in that way, or from your parents?
Using the same strategies that you do to the parents. As I said, like I blocked most of it out of my memory, so I don't on their faces, and I was also pretty young. But I do still feel a guilt for like making me go through that. I'd say the same stuff as the patient.
That's a good question.
It's a
Like,
good
so
question.
like, I'm not sure quite how to answer it, because you try to protect your kid. And so sometimes you try to hide your fears, but then, yeah. I don't know if we're even talking about emotional transference, or there's just a lot of complexity in that. Do you have an answer?
As far as like, it depends on the scenario, but we'd spend a lot of time in the infusion center. So a lot of times, like if my anxiety is up, that's gonna amp the child up, right? So they do a really great job of being like, okay, Meg, maybe you should go take a walk, get a coffee, like just kind of give those cues that you might not be thinking about in that moment because you're so concerned about your kid. So in that setting, I could see those kinds of things being helpful to kind of diffuse and give the parent permission to say, I can take a break. I think that's the biggest thing. The best advice I've gotten along this journey is several providers saying to me, you're not gonna be able to do everything. You can't do everything. So you throw at me a litany of every PT, OT, therapy under the sun. How am I gonna get my kid to every single one of those things, right? So just kind of permission to say, hey, you're doing the best you can, and pick one or two things, and we're gonna help you. We're gonna give you a break, and here's a gift card for some coffee or whatever, I think that helps with the parent, for me anyway, parent anxiety piece, but it does, I know when my anxiety goes up, Jordan's or my son. So that is an important piece.
Can do Jordan to kind of help gain trust before we lose it.
Like not like throwing everything at them. Like I said, like the doctor that like talked as if I wasn't there and told my parents like 6 procedures I should have done. Like taking it slow is like really important. Hey, if this gives us what we want, then we can go down this road. And get slow with small steps.
One error I realized that I have made at times, I could tell you specific times, but is just minimizing significance of certain things, thinking that helps. Be like, oh, this isn't that bad. And then it's like, yeah, it was. And I just remember one time we did ultrasound, which is, the most anodyne, it's just this, but she was so terrified from previous things that just taking the wand, and it took like probably 45 minutes from them like showing, oh, here it's on my skin, you want to try your hand. Just because I think there was that broken trust that we had minimized, like whether it's a shot or this, or a little poke, oh, it's not that bad. And for a kid, like Connie shared with her daughter, to them it is. So that's my 2 cents, yeah, from my experience.
The question is a high school provider. Unfortunately, I don't think a lot of sometimes if you of doing something, and it's not, public safety. Luckily, I get drugs, and you guys, I can give drugs, which helps. How would be a good way to approach that? I mean, I would not in any way trying to like make it a trick question. I would love advice on that, because it is, you know, I've looked at my kids and I'm like, sorry, this is really gonna suck. You know, to my children, when I've had to say, yeah, I know you don't like shots, but and it's gonna suck and it hurts and this is what's gonna happen, but we're gonna do it anyway. And no, so how, when you have to do something and you know it's not a choice and you know they're not gonna like it and it's not gonna be a good experience, how do you walk through that, Jordan? How would you like that to happen?
Like just knowing what's gonna happen, not like walking them in blind. And I can see if it's like completely like urgent, then I feel like there's still time for a little explanation. And said you could say, do you want an orange Band-Aid or a blue Band-Aid? And like giving them those tiny little things like.
Add to that. So I'm a clinical psychologist and work at USD Center for Disabilities, and I just so appreciate everything that you've said today. I'm so glad you guys are covering this topic. It's just awesome. But to kind of reiterate with this, don't ever like forget the importance of repairing a relationship after something has happened, right? So we needed to do something that was imperative. This was why, and really walking through that after the fact and like, what can we do to get back to a good place? Because I had to make this choice as your parent or as your medical professional to do that. But then again, like that repairment after is just, I just don't minimize that part. I think I would say is like, that's really important.
I think that's very true. Like with our son, he was diagnosed at age 3 and started his first infusions on Rare Disease Day in 2017. And he didn't like, he was terrified. He screamed. IV start was terrible. Like, and he has to get them every 2 weeks to save his life, right? So he's had 183 infusions. Well, now we're at a point working with child life, like going backwards, like you said, saying, okay, this isn't fun. Sorry, this sucks that you have to do this. This is saving your life. And now like I didn't take that long, but he like rocks all the IV starts just because of the conversations of going back and saying, you know, this had to happen. And these are the reasons why, and it sucks. Sorry. I mean, maybe in a different way, but you know what I mean? Like there are things that you just have to do in life where emergencies come up and you have to hold a kid down, and it's probably not the best thing, but you have to do it. Just circling back.
And I feel like he's a success story of child life that like after his first maybe 15 infusions, he stopped even crying during the poke. He just took it. Again, and there was also some psychological work to do after the fact of like, we realized he was kind of dissociating, and there's some work to do there. That it's like, oh, it seemed like he's so resilient, but there are costs to that. But the fact that Wendy packed up a kit to send home of like all the different things, and we would practice, we would the
Cold soap,
and tight band, like all the things, and we would use the names that they would use and just practice it. So she was just familiar with it, and even just the options of it's funny to go from the invasiveness of an IV start, like that being the difficult thing, to thing he didn't like at the end was the feeling of adhesives being pulled off his skin. He didn't like that, and so his nurse brought in like he gets to use all the spray that he wants, whatever that spray is called, that like breaks down the adhesive, and also he gets to pull off himself. So like the nurse gave him the option on his timing to do that, rather than just being like, all right, we're gonna do this 1, 2, 3, like just I guess including his input, even at a pretty young age, that he's able, like even that unpleasant part of it became just like not a big deal. And I just appreciate the way that they did it. It like there are total success stories, and it like there are ways like a necessary thing can become just routine in a very healthy way.
Yeah, and if it's a consistent thing, like my brother's 2 weeks, so having a routine is like, so like when he gets his IV start, like he'll sit on a parent's lap, and then afterwards he'll the nurses at the pillow.
Yeah.
And
That's her fault.
Yeah.
And then like at the end, Will gets to get off on his own time, that's like,
it's really helpful, it's definitely minimized.
And I know we're trying to get out of here, but like, I just thought this was a very personal, specific example of, you know, everything that they presented, like the theory. I just wanted to present like a personal example of it.
Yeah.
In practice.
And we didn't get into the treatment of, but I guess I would advocate for mental health being just as important for kids. You know, and I asked Jordan, she said, okay, but both our kids have therapists that we work with, and I find that to be extremely important in our story. So don't hesitate to reach out for that kind of help too, or suggest it for kids or families.
there's and doors.
Yes,
Can I say that?
yes,
Because I think as parents, we oftentimes think,
Oh, I'm helping them, they're getting that, and but you're not, you know, and so, and again, when you talked about the relationship of the family and making sure you're really listening to where the family is and seeing where the family's at, that child is only as healthy as the parents are. And so you have to have them in that equation. If they're not, then it's just,
And maybe that's, like, I felt bad I didn't have any answer for you, but we can use the analogy of when you're in an aircraft and you lose cabin pressure and the masks fall, the instructions to you are to first put your mask on before you help anyone else. And so as a parent, just making sure that you're getting that self-care, because it's gonna be hard to really assist your kids if you're just at your wit's end. It'll be really hard to help them.
did have one comment online from Amber Johnson. She said, "Hi, my name is Amber. I'm a nurse practitioner who happens to have a child with rare disease and epilepsy. I feel supporting parents through their journey is truly key. Medical trauma is not only about the patient, but the parents too. We struggled with it hugely. And being a healthcare provider, I knew what was happening and I still struggle. You're still alone very often."
I have a question about how you, I had a patient that I was seeing for a little time in short semesters, who needed a GU exam, reading and things like that. I was not going over well with the patient. And so I did some motivational interviewing and asked some questions and then gave him some time with his mom. And then I came back and I said, this is pertinent for kind of like getting to the end. And then we went over some options about like, well, I don't necessarily need to like touch you, but I would like to see if there's any hair growth, things like that from there. He was very reticent to that. And his mom then said, well, we just need to do it. Just need to get it done. So then that put me in kind of an awkward position between the parent who didn't want to come back for another exam, and then the kid who had a lot of, he was kind of cowering behind the table. So from a provider standpoint or from child life, how do you navigate those kind of situations?
You and I might have different answers, I don't know. I'll answer real quick. So we have that like multiple times a day in our clinic that they're behind or underneath the exam table and they don't want to do something. And so like to Lesta's point, often it's with a stern voice of, we don't have a choice, this has to be done. We have choices of what you can do. This is not one of them. And so we will spell out exactly what the steps are and what the privacy, so I don't know how old your patient was, but especially given if it is an adolescent and we want to offer as much privacy as possible, and I assume you have to have two people in the room, and so being cognizant and putting an extra blanket over and offering some, and maybe perhaps it's that he or she wanted mom to turn around. I mean, some things like that come to my mind, like offering some privacy things that maybe we don't necessarily think of right away. So maybe mom needed to stay in the room for safety reasons, but perhaps mom can face the wall to offer that privacy so you and your physician can have that contact. And then just giving that directness that it's not a choice, we have to do this. I can offer you this choice or this choice, whether you want to, I don't know, have mom face the wall, or do you want mom to step out and my nurse to come in, or whatever choice you can come up with. If you can come up with anything to be a choice, to feel like he's got some mastery, we would do that. We give that directness, no choice in, it has to be done. And we often advocate for not coming back because they will find every excuse not to return and or the hardship that that puts on the challenged parent anyway to be the bad guy to get them to come back in. And so we will work really hard to give them some power and to give them the steps of what's gonna happen, even so simple of, so we're gonna let you can take your undies down, we're gonna cover you completely. We're not gonna touch, like you had mentioned, we're not gonna touch you, we're gonna do whatever step is gonna be done, we're gonna give them absolutely every step that's gonna be done. And then when it's done, what every step's gonna be, so he has privacy to regain his pants back on and then has that privacy back. So that's what we would probably advocate for.
I think about the same thing. I just maybe just understanding more what the reason, what the hesitance was, if it was just maybe he thought you were taking pictures or something like that. Just making sure you understood everything that was causing him to not want to do it. Yeah.
He was nervous about being gay. And so that was like part of it. And it was difficult for me because I pictured myself in, I therapy room 15, 30 years down the road, trauma and stuff, and I didn't want to be a part of that. So it was, thank you so much. That was